Module 5, Cardiac. This recording will cover Chapter 28, Assessment of Cardiovascular Function. We start with an overview of the cardiovascular system. The primary function of our heart and vessels is to deliver oxygenated blood to tissues and to return deoxygenated blood back to the heart. Next, we have a picture of the major anatomical structures of the heart. Left is a drawn picture, and on the right, you can see the real thing. So let's talk about our vascular system. So this consists of arteries, veins, and capillaries. And like we mentioned before, the functions include oxygen delivery to tissues, removing waste products, returning blood to the right side of the heart, and also returning lymph fluid to general circulation. The arterial system. So this is a high pressure system. Arteries have thick muscular walls, and they carry oxygenated blood from the heart to the cells, tissues, and organs. So there are different sizes of arteries, and it begins with arteries to arterioles to meta-arterioles to capillaries, capillaries being the tiniest of the vessels. Next, we have our venous system. So this is a low pressure system, unlike our arterial system. And our venous system, or our veins, also contain valves. So arteries don't have valves. And the purpose of the valves are to prevent backflow of blood from going the wrong direction. Now, capillaries is where arteries and veins connect. So when arteries leave the heart, that's a really big artery, and then they get tinier to the capillaries. And then when it meets the venous system, those veins get bigger. So it goes capillaries, venules, veins, and then it connects to the right side of the heart where the process is cycled again. And finally, we have our capillary system. So this is where the magic happens. This is where oxygen and nutrients are delivered and waste is removed. We have billions of capillaries throughout our whole body, and something special about them is that they have the ability to constrict or dilate and even divert blood to wherever there's a need for it. So if there's something going on in the body and we need more blood to our priority organs, then this capillary system is going to shunt it away from what's not important. Like, for example, our most distal extremities, like our fingers and our toes, which is why they can get cold and pale. It is the capillaries that are controlling that. This slide just shows another picture of an artery versus a vein, and it also shows you an example of what a capillary looks like under the microscope. Another picture from your textbook that depicts arterial and venous blood flow. You can see where they meet. That is capillaries, capillary bed. Moving on to the anatomy of the heart. So the heart is a hollow organ, and it is about the size of your fist. It is in our chest, between the lungs, and it sits behind our sternum and rests actually on our diaphragm. So it is behind a really strong, thick bone for a reason, because it is one of our most vital organs, and that sternum protects it. Next, we look at the layers of the heart. So using your medical terminology prefixes, we can easily figure out which layer it's referring to. So endocardium is the most inner lining of the heart. Then we have myocardium, myo meaning muscle, so this is the actual muscle of the heart. Epicardium is the outside of the heart layer. And then we have pericardium, which is like the sac, a really thin sac that the heart sits in. So next we're looking at the chambers and the valves of the heart. So the heart has 4 chambers, a right and left atrium and a right and left ventricle. It also has 4 valves. So we have 2 AV valves, which are the tricuspid valve, bicuspid valve, which is also known as the mitral valve. And then we have 2 semilunar valves, pulmonic and aortic. So these structures are important when we learn about the blood flow through the heart. So here we have it, the pathway of blood through the heart. So deoxygenated blood enters the heart via the superior vena cava and inferior vena cava. It comes into the right atrium, and then it passes through the tricuspid valve into the right ventricle. From there, it is squeezed into the pulmonary artery, which will then go to the lungs. The blood will get reoxygenated, and then it will come back to the heart via the pulmonary vein. From the pulmonary vein, it goes into the left atrium, through the mitral valve or bicuspid valve, into the left ventricle. Once that left ventricle squeezes, it pushes that heart that's now oxygenated through the aortic valve, which then goes through the aorta into systemic circulation.
Blood returns from the body to the heart via the superior and inferior vena cavae. It first enters into the right atrium, then through the tricuspid valve and into the right ventricle. The right ventricle pumps the deoxygenated blood through the pulmonary artery to the lungs. The oxygenated blood returns back to the heart through the pulmonary vein and into the left atrium. It goes through the mitral valve and finally into the left ventricle, which is responsible for pumping the oxygenated blood through the aorta and out to the body.
Now we take a look at the blood supply to the actual heart itself. So we're first starting off with the left coronary artery. So you can see in this picture there's a star where the left coronary artery sits, and it branches into the left anterior descending or LAD branch and the circumflex branch. So these vessels supply both ventricles, the anterior interventricular septum, anterior wall of the heart, left atrium, and posterior wall of the left ventricle with blood. So if you have a blockage really high up, like in the LAD, really high up of the heart, then you're going to have a lot of deficits. You're going to have a lot of dying tissue versus if you have some type of blockage way down, most distal from that LAD branch. Then, just like the left side, we have something similar on the right side. So this is the right coronary artery, pictured here with the star. It also has two branches, the right marginal branch, posterior interventricular branch, and these supply blood to the right atrium and ventricle, and then behind the heart to both ventricles and interventricular septum. So again, what this means to you is that a patient can develop an obstruction, a blood clot, or some kind of narrowing vessel due to maybe atherosclerosis anywhere in these vessels, and depending on where it's located and how severe that obstruction is will determine how much damage the heart will have. Okay, so it's just another picture, blood supply to the heart. And now we're moving on to the cardiac conduction system. So this picture shows the cardiac conduction system, and this green pathway is electricity. So here where you see my little pointer is the sinoatrial node, or SA node for short. Remember that a node is just a collection of specialized cells. So in this case, this node is full of special cardiac conducting cells. So this is going to create an electrical impulse. So SA node right here, we have Bachmann's bundle. This is going to be on our left atrium. And then the signal travels down to the AV node, which is right here, through the bundle of His, this interventricular septum here, to the left and right bundle branches. And then it finally terminates in the Purkinje fibers. So this picture shows a numbered version of the order of this electrical impulse. So again, it starts in the SA node and then goes down through the atriomyocardium. It jumps to the other side, to the left side. Then it goes to the AV node, through the bundle of His, to both bundle branches, and it terminates in the Purkinje fibers.
This animation explains how a cardiac cycle is produced by electrical impulses in the heart. The cardiac cycle starts when an electrical impulse or action potential is generated by the sinoatrial node. The electrical impulse travels along specialized conducting fibers in the walls of the atria, stimulating the atria to contract and pump blood into the ventricles. In the normal heart, impulse travels very rapidly. As a result, all the muscle cells in the atria contract together, producing a coordinated pumping action. The impulse also travels across the right atrium to the atrioventricular node, where it is delayed slightly to allow the ventricles to relax and fill with blood before they contract. The impulse travels along the bundle of His, where the conducting pathways divide in two, forming the left and right bundle branches, which lie in the interventricular septum. From the bundle branches, the impulse spreads into the inner walls of the ventricles via specialized conducting fibers, called Purkinje fibers. Finally, the impulse travels up the outer walls of the ventricles towards the atria. The rapid and controlled spread of the electrical impulse through the ventricles stimulates the muscle cells in the ventricles, to contract together and pump blood efficiently to the lungs and body.
So here we have the SA node, the AV node, and the Purkinje fibers. So all three of these areas can start an electrical impulse, but the SA node is where it should begin in a normal working heart. And it can fire from 60 to 100 times per minute, which is where we get our normal resting heart rate from. Now, if the SA node fails for some reason, then the AV node should be able to keep the heart beating between 40 and 60 beats per minute. Now, if the SA node and the AV node, we do have the Purkinje fibers that could potentially keep the heart squeezing or contracting at least 30 to 40 times per minute. Moving on to the cardiac cycle. So the cardiac cycle is systole and diastole. So the heart is squeezing and then it fills again, squeezes, fills again. That is the cardiac cycle. That brings us to blood pressure. So by definition, blood pressure is the force exerted against the vessel wall by blood flow. And we measure this in systolic and diastolic values. So factors that influence blood pressure are going to be the amount of blood ejected during systole, which is when the heart squeezes, and the resistance to flow in the peripheral vessels, which we call peripheral vascular resistance. So BP is cardiac output times PVR. So what is cardiac output? So the name is telling you it's what's coming out of the heart, and by definition, it is how much blood is pumped out in 1 minute. A normal cardiac output for an adult is about 4 to 8 liters per minute, which is a pretty good amount. And the formula for cardiac output is heart rate times stroke volume. So the reason why we keep talking about cardiac output, or we will be talking a lot about cardiac output, is because the output is going to dictate how much oxygenated blood the body gets, or the cells, tissues, and organs receive. So first we have the heart rate, and this is going to be the number of cardiac contractions per minute. We know that. And there are several things that can influence a heart rate. So our autonomic nervous system, sympathetic nervous system, a parasympathetic nervous system. Remember, they work in opposition of each other. And also, our endocrine system, hormones. So there's a lot of things. You can be scared, you can be happy, you can be exercising. All of those things could potentially change your heart rate. Then we have stroke volume. By definition, this is the amount of blood ejected with each ventricular contraction. So the amount of blood that's coming out of the ventricles. This is going to be influenced by preload, contractility, and afterload. So let's talk about preload. So preload is the load on the ventricle muscle at the end of diastole. So remember, diastole is the filling time. So the ventricles are filling with blood. So right before the ventricles squeeze out that blood, that is the preload. So it's the max capacity of blood that fits in the ventricle before it squeezes. So there are several things that can change your preload either up or down, such as circulating blood volume. So if you have a lot of blood volume, then you're going to have a lot more preload because there's a lot more blood going into the ventricles. Versus if you're really dehydrated, you're really dry, maybe you're hemorrhaging out, you don't have a lot of blood, then that's going to make your preload decrease because you don't have the volume in the ventricles. Venous tone, we're talking about our veins. So remember, our veins can constrict and they can dilate. So depending on what they're doing, can also affect the amount of blood that's coming into the ventricles. Next, we have muscle contraction. So if you're exercising, your body is trying to optimize oxygen delivery, so your preload may change, it may increase. Cardiac valve function. So we have valves in our heart. Remember, we have 4 valves, and if one of those isn't working right and the blood is starting to back up in the heart and mixing where it shouldn't be mixing, that could also affect the preload because blood that should be moving forward is staying behind. Then we have heart failure. So heart failure, which we talk about later, is a weak heart that's not able to pump effectively. So that means a lot of blood is going to stay behind and pool. So that is going to affect our preload. Now, one thing to note is that preload and cardiac output have a relationship. So if you have increased preload, then you're going to have increased cardiac output, and vice versa. Decreased preload will equal decreased cardiac output. So more about preload. So what are some reasons we would want to increase preload? So if the patient is severely dehydrated, they're losing blood, they're hemorrhaging, or they're experiencing hypovolemic shock, we want to increase the preload. If there's not enough preload, that's going to result in not enough cardiac output. Oxygenated blood is not coming out to our cells, tissues, and organs. So how do we increase preload? Well, we can give fluids, we can give blood products if the patient needs it, and we can also position the patient temporarily, like pictured here in Trendelenburg. Now, this is not a fix, it is not a cure, it is a temporary measure while you get your stuff together and you get help. This will kind of like guide the fluid in the extremities down back to the heart. Now, just a disclaimer, you want to use this cautiously, and usually in the intensive care setting in ICU, we do not do this because the patient can end up with other problems. So in a critically ill patient, we aren't putting them in Trendelenburg. But if you have a patient, for example, who is very, very dehydrated, that is the reason, then giving them a temporary boost of fluid, such as putting them in this position, might be helpful, for a few minutes. So when would we want to decrease preload? Okay, so the previous slide was increasing preload. So when would we want to decrease it? So one example is during heart failure. So in heart failure, the pumper is very weak. The heart muscle is very weak, and we're trying to kind of give it a break. We don't want it to have to process so much fluid. So that would be a reason why we would want to decrease the amount of blood coming into the ventricles, or AKA the preload. And that will hopefully decrease the work that the heart has to do. So how do we do this? So this is going to be the opposite of preload. We're going to try to get fluid out of the body, so possibly diuretics, maybe fluid restrictions so the patient isn't taking in a lot of fluid, limiting sodium intake because we know with sodium comes fluid, and positioning. So we could actually sit these patients up in high Fowlers, and gravity will kind of help pull blood away from the chest and heart, which could help, decrease preload. So decreasing preload helps the heart not get overloaded. It helps breathing. It makes it a little easier, especially in those heart failure patients. Moving on to contractility. So contractility is the force of the muscle of the heart, how well it contracts. And there is a relationship also between contractility and cardiac output. So increased contractility will result in increased cardiac output, whereas the opposite, decreased contractility, will equal decreased cardiac output. So things that can influence how strong that heart contracts. Again, our sympathetic and parasympathetic nervous systems, hormones, electrolytes, some medications, some diseases, your age, and genetics. So when would we want to increase the force of that squeeze, increase contractility? So in heart failure, because that is the problem with heart failure, you have a weak pumper, weak heart, or when a patient is in shock. So the heart isn't pumping strong enough. So that is when we would want to increase that contractility. Increasing contractility will hopefully push more blood out, increase or improves cardiac output. So how do we do this? We are going to do this with medications. That's going to be the first option. Specifically positive inotropic medications such as dobutamine, dopamine, and digoxin. This is going to make the heart muscle contract stronger, therefore increasing contractility. Hopefully more blood is pumped out and oxygen gets to our cells, tissues, and organs. Now we can also help to correct hypoxia. So if the heart is starved of blood, then it's going to weaken the heart. It doesn't have what it needs to perform optimally. So if we can correct that, that will help also. Correcting electrolyte imbalances, especially calcium and potassium. So if you have abnormal calcium and potassium levels, no matter what we do, it really isn't going to change anything. It's not going to help. So we really have to make sure those are right, oxygen is good, and then we could give medications that can further help contract that heart muscle. Okay, so what about decreasing contractility? So this isn't as common as trying to increase contractility. So we would do this when we're trying to let the heart rest and we don't want it working too hard. One example is if the patient had a major myocardial infarction and during an MI there is ischemia, there's a blocked vessel and there is tissue death. So if you had a major MI, then the heart muscle is going to be weak and we just want it to rest while it recovers. So this would be a reason to decrease contractility. This can be done with beta blockers and certain calcium channel blockers. So for the beta blockers, we have metoprolol, propranolol, those are common ones, and then certain calcium channel blockers like verapamil and diltiazem. So overall, we mostly increase contractility. That's what you're going to see most, but in some cases, we actually may want to decrease contractility. Then we have afterload. So afterload is going to be the pressure against which the heart will work. So what does that mean? So once the blood is in the ventricles are going to squeeze and one side is going to send blood to the lungs and the other side is going to send blood out through the aorta into the rest of the body. But what happens if your aorta or your arteries are narrowed? That blood is going to have a harder time getting through versus a person who doesn't have any narrowed arteries. That is afterload. So the person that has the narrowed arteries, that heart is going to have to squeeze with more force. It's going to have to work harder to get the blood out of the ventricles into its next, wherever it's going, whether it's the lungs or the rest of the body. So that is afterload. So some things that can influence afterload is blood pressure. That's a big one. If you are hypertensive, the heart has to work harder to get the blood out of it. So that would be increased afterload with hypertension. Also, a vessel lumen diameter and vessel compliance. So the example I gave with constricted, narrowed vessels, that's going to affect afterload. Vessel compliance. So if the vessel isn't able to give way a little bit, if it's really stiff, it's not able to be elastic and, kind of like accommodate different volumes of fluid in it, then that's also going to increase afterload. If you have really stiff vessels, then that's going to have increased afterload. The heart's going to have to work harder. So afterload has a relationship with cardiac output. Now, it's inverse, unlike preload and contractility. So afterload, if you have increased afterload, you're going to have decreased cardiac output. If you have decreased afterload, you're going to have increased cardiac output. So when and why do we want to decrease afterload? So just like the examples that I gave, hypertension or heart failure, the heart has to work really hard to push out the blood. So we want to decrease that workload. We want to decrease that afterload. So how do we do that? One way is with vasodilators. We want to dilate those vessels so that blood can move more freely through them. Examples of medications that do this would be nitroglycerin, hydralazine, and some ACE inhibitors like lisinopril. So this is going to relax blood vessels, which will have lower resistance on that blood, and hopefully the heart has an easier time pushing blood out. Calcium channel blockers, only certain ones like amlodipine and nifedipine, will relax and widen arteries and have the same effect, hopefully will decrease afterload. And most importantly, well, not most importantly, but very important, is blood pressure. If a patient has hypertension, has high blood pressure, they just need to take their blood pressure medication, and that will decrease afterload. So medication compliance and managing that blood pressure to stay within normal limits will automatically lower afterload. So is there a time where we want to increase afterload? Because it sounds like increased afterload is bad. You always want to decrease. So this is less common, but it is something that's done in certain circumstances. So in distributive type shocks, so where the vessels become very, very dilated from head to toe, we want to actually increase that. We want to constrict those vessels. So that would be increasing afterload. So that's the most common scenario that you're going to see this done. And we would do that with vasopressors like norepinephrine, aka level fed. This is going to constrict the vessels and raise the blood pressure. So in that scenario, yes, we want to increase afterload. But most of the time we're trying to decrease it. Okay, so cardiac output. So preload and afterload are reflected by measurements through a centrally located IV catheter. So this is for patients who have invasive hemodynamic monitoring. We can actually get measurements of what the actual preload and afterload is. And this would be done, of course, in the intensive care setting.
With each contraction of the ventricles, blood is pumped out of the heart. Stroke volume is the amount of blood a ventricle pumps out in one contraction. Cardiac output is the volume of blood that each ventricle ejects every minute. To find the cardiac output volume, multiply the number of heartbeats in 1 minute by the stroke volume. At rest, the cardiac output for an average adult male is about 5.25 liters, 4.9 liters for an adult woman. Cardiac output increases with physical activity, rising to a maximum that may be 4 to 7 times greater than the resting output. This difference between resting and maximum output is known as cardiac reserve. Heart rate and stroke volume are regulated by the autonomic nervous system and by hormones in the bloodstream. Other factors such as age, weight, and physical fitness also influence cardiac output.
And this is just another picture depicting preload and afterload. Okay, so now we're going to talk about blood pressure. Now the formula for blood pressure is cardiac output times peripheral vascular resistance. So we know what cardiac output is. What is PVR, or peripheral vascular resistance? So this is going to be that resistance that the blood encounters when it's flowing through vessels in the periphery of the body. So pretty much our arms and our legs. What kind of resistance is it going to meet? And this is going to influence the force required by the heart to actually get through. So it's all like the same stuff that we're talking about. So factors that can influence PVR, remember PVR, peripheral vascular resistance, is going to be vessel diameter. So is it constricted? Is it dilated? Does the patient have atherosclerosis or plaque that's making the vessels very narrowed? Blood viscosity. So if your blood is very concentrated and thick, like if you're very, very dehydrated, then that's going to give you a lot of resistance in those vessels with the blood trying to move through it. Body weight and body height. So if you have more surface area to travel, that's also going to cause more peripheral vascular resistance. So we're going to talk about these values, systolic and diastolic values, and what that actually means when you're reading a blood pressure. So the systolic value is the peak pressure generated when blood is expelled from the left ventricle during ventricular contraction. So here we have our heart filling with blood, the left ventricle. And when it squeezes, that blood is squeezed out through the aorta to the rest of the body. So during that squeeze, that force, that blood, when it hits the vessel wall, that is our systolic value. When the heart is resting, when those ventricles are resting and filling, and the blood that's currently in the body is just kind of sitting there in between beats, that is the diastolic pressure. So if we say a patient has a blood pressure of 120/70, it means that at any given time, the pressure against the vessel wall is between 120 and 70 millimeters of mercury. It's a range. So there you have it. The range of artery pressure for this would be 70 to 120 millimeters of mercury. So just some facts about blood pressure. So the primary factor that determines your systolic blood pressure is stroke volume. The increase in preload or increase in contractility is going to increase stroke volume, which will increase your systolic blood pressure. A decrease in compliance of vessels, so the ability of the vessels to kind of stretch and come back to their normal size, increases systolic blood pressure. And you can see this is age related. So just by us getting older, it is expected that our blood pressure will be a little bit elevated. The primary factor of determining diastolic blood pressure, so the lower number, is total peripheral resistance. So everything is tied together. Next is mean arterial pressure, or MAP. So MAP is the average pressure maintained throughout the cardiac cycle. It is an average. So when we think about MAP, we also have to include the concept of time. So in the cardiac cycle, we have systole and we have diastole. So systole is squeezing or contracting, and then diastole is when the ventricles are relaxed. So when we think about it on a timeline, systole is much faster than diastole. So when the heart squeezes, it takes time. But while the heart is filling, it actually takes double the time of systole. So if you look here, we have 1/3 of the cardiac cycle is systole versus 2/3, and we're talking about time, of the cardiac cycle is diastole, or resting or filling. So that is where we get our numbers. So the formula here for MAP is going to be 2 diastole numbers, so 2 diastole values. So in this example, 120/70, we're going to go 2 times 70 because 70 is our diastole value and it takes twice the time. That's why we're doing 2. Plus, we're going to do 120, which is our systole time. We're going to divide it by 3 because we're trying to get the average. That is the MAP. So in this example, 120/70, the MAP is 86.6. So what is the significance of a MAP? So this is an indicator of how well our organs are being perfused. So science, research, trials have determined that for optimal perfusion, and remember, perfusion is oxygen getting to where it needs to go, to our tissues and our organs, we need a minimum MAP of 60. So the MAP is typically more used or looked at in the sicker your patient gets. If you work on a regular Med-Surg floor, you're typically not documenting the MAP or taking the MAP into consideration as often as you would in a patient who is in step-down ICU or is in ICU. But it's good for every nurse, everybody to know what is MAP and what the significance that is to oxygen and perfusion. So we've heard the word compliance. So what is compliance and elasticity when we're talking about vessels? Actually, we also use the word compliance and elasticity when we talk about lungs because it's very similar to vessels. So compliance is the ability of vessels to stretch or dilate. So if the vessel can easily stretch, then it is highly compliant. Versus elasticity, this is the tendency to rebound to its original size from a stretch. So once it's stretched out, it's very compliant. Can it go back down to its original size? That is elasticity. So compliance and elasticity go hand in hand. And we need our vessels to do this in order to function properly. Okay, so we're moving now on to our cardiovascular assessment. So we have a patient that presents to the office. What are we asking them? What are we looking at? So we're going to consider a family history of cardiovascular disease because it tends to run in families, diabetes, chronic kidney disease, hypertension, and dyslipidemia, which is high cholesterol. We want to look at those non-modifiable risk factors such as age, sex, and ethnic background. We really want to focus on those modifiable risk factors. So if they're overweight, do they have poor diet? Do they drink a lot of alcohol? Do they have a history of smoking? How active are they? And their socioeconomic status. So we also want to ask about current problems. What's happening right now? So are they diabetic? Do they have kidney issues? Do they have hypertension? Do they have cholesterol issues? These are all risk factors for cardiovascular disease. Presence of chest pain, dyspnea, cough, palpitations, edema, fatigue, syncope. So all of those signs are kind of nonspecific because they could mean other things too. It can be part of a respiratory problem, a renal problem, or it could be a heart problem. But these signs and symptoms have to be looked at and to make sure that we rule out other causes, but these can all be part of a cardiovascular problem. Chest pain. If a patient presents with chest pain, you're going to ask, where exactly are you having the pain? Intensity, so how severe is the pain? Does it radiate to any other body part? Duration, how long is this happening for? And quality, like describe it. Is it sharp? Is it dull? Then we have dyspnea and fatigue at rest or dyspnea on exertion. So we expect some shortness of breath and fatigue during certain activities. So if you're running a marathon, if you're running around the block, stuff like that, we would expect you to be short of breath and possibly fatigued. But if you are resting, if you're not doing any activity and you have these symptoms, then that is definitely not normal, and that patient is a priority that needs to be reported. Is the patient experiencing palpitations? If a patient has palpitations, we kind of think that might be a dysrhythmia. If a patient has syncope, syncope is fainting or passing out. You could also have near syncope where you feel like you're going to, but you didn't. We think, maybe you have decreased cardiac output for some reason. Maybe there isn't enough oxygenated blood leaving your heart and didn't get to your brain and it caused this syncope. Does the patient have weight gain? Are they gaining weight quickly And are they having edema? Is the weight gain from the edema? Could this be heart failure? Because when you have heart failure, you tend to retain fluid because the heart can't pump it out, so you get edema. Now, if you have edema with weight gain, it could also mean other things. It not necessarily has to do with your heart, but we are going to consider that. This picture here is a nice little recap of your cardiovascular assessment. So our general assessment for the cardiovascular system is going to include a good neurovascular system because we're talking about vessels coming from the heart. This is going to include color, temperature, so is it pale, is it flushed, is it warm, is it cool? Diaphoresis, so sweating, edema, restlessness, agitation, confusion, that can be related to oxygen status, weight, fluid status, shortness of breath, mobility, and of course we're going to assess our vital signs, especially our blood pressure and heart rate. So blood pressure and heart rate, what is the significance of that when we're talking about the cardiovascular system? So a heart rate can tell you whether the patient is having issues with cardiac output or if they're at risk of having cardiac output concerns. So a decreased heart rate could be normal. It could just mean that the patient is an athlete, very good condition, good physical conditioning, or it can mean that the patient has inadequate cardiac output. If you have a low heart rate with symptoms like dizziness, shortness of breath, or chest pain, that is an emergency. We need to get that checked out. If the patient has a high heart rate, it might just mean it's a normal physiological response to whatever the patient's doing. Maybe you are exercising or doing something out of your normal routine that could naturally increase your heart rate. But if you have a high heart rate at rest and that is not considered normal, we kind of have to do some more investigating to see why. If you're in pain, if you have a fever, that can naturally raise your heart rate, but your heart rate can also increase if your heart muscle is weak. So we definitely want to investigate further. And we know that our heart compensates by becoming tachycardic if we are hypovolemic. Pulse deficit. This is when your radial pulse is different from your apical pulse, and when we assess that, then we would consider an arrhythmia. What is the significance of blood pressure? So this is the force of heart's contraction and volume of cardiac output. And if you have a low blood pressure with symptoms like postural hypertension, dizziness, shortness of breath, we are thinking you have an inadequate cardiac output or blood volume. We need to check that out further. If you have increased blood pressure, we're thinking more resistance in the vessels, and that's going to require higher pressures to produce an adequate cardiac output. So again, we also want to check into this further. If you have high blood pressure or hypertension, you're at risk of developing heart failure, a myocardial infarction, and or stroke. Okay, moving on to our physical assessment, inspection. So we could see cyanosis. We're going to check capillary refill time. We're going to check to see if there's presence of distended jugular veins or JVD. That can be an indication of fluid overload with left-sided heart failure. Clubbing of fingers and toes. This is long-term oxygenation problems. Continuing on with inspection, we're going to check for edema. Bilateral lower extremity edema. If there is no injury or no indication of the reason for the inflammation, then it could a lot of times mean that there is some type of venous insufficiency where the veins are having a hard time returning that blood back to the heart, or it could even mean heart failure. If there is just one extremity that is edematous, then it can mean there's an obstruction of some kind. That's if there's no injury present. And then a reminder that edema can be pitting or non-pitting. So an example of non-pitting edema would be lymphedema. Moving on to palpation. So this is where you're touching the skin. We're going to look at skin temperature. So if you have an extremity that is cool or cold, it could mean that there's lack of blood flow, vasoconstriction, heart failure, shock. If there is different temperatures in different parts of the bodies, there could be some type of vascular constriction or vascular disease. We're going to check pulses. Remember, pulses, when you check them, it is an artery that you're feeling the pulse with. So this could also indicate, normal or abnormal cardiac output. And if we have good flow through those peripheral arteries. Moving on to auscultation, so we're going to listen to heart sounds. This table gives you a nice little description, a review of your S1, S2, S3, S4 sounds, murmurs, and clicking sounds or friction rubs, and what it could mean. When we assess our cardiovascular system, we also assess the respiratory system because they are best friends and they go hand in hand. So we want to listen to breath sounds, and rales, crackles, rhonchi rubs can be indicative of fluid, pulmonary disease, CHF or congestive heart failure, and just overall decreased cardiac function. Next, we're going to talk about diagnostic studies, and first is laboratory markers as predictors of heart disease. So we're talking about lab work specific to assessing our cardiovascular system. We're starting with the lipid panel. A lipid panel includes our LDL, HDL, and then our total cholesterol, which would be our LDL plus HDL, and triglycerides. So we're going to talk about what LDL is and HDL on the next slide. But triglycerides is a type of lipid, and we want that level to be lower than 150. All right, so we're talking about LDL and HDL. So first, let's understand what cholesterol is. So cholesterol comes from ingesting animal products like meat, poultry, and dairy, and cholesterol is also made in the liver. Cholesterol is a fat-like waxy substance, and it's not soluble in blood, so it just kind of floats around. So where does the LDL and HDL come in? So these are proteins, LDL and HDL. They are transport proteins. And starting with LDL, you see that here in the first little red truck. It transports cholesterol into cell and into arterial vessel walls. Okay, so LDL transports cholesterol into arterial vessel walls where it will later become plaque. Plaque leading, atherosclerosis, which we talk about in the next chapter. HDL is also a transport protein, but it transports cholesterol to the liver for excretion. The liver will excrete cholesterol as bile. So which one do you think we would prefer to have more of? Either the transporter that's taking our cholesterol into our arterial vessel walls, or the transporter that's going to take it to the liver to get it out of the body? Yes, we want a high HDL and a low LDL. That is the goal. So LDL we want lower than 100, and HDL we would like it higher than 60. More labs that we can look at if a patient is having chest pain or we suspect a patient is having a myocardial infarction is creatinine kinase, or CK. This is a general marker of cellular injury, so it's not specific to the heart, it's just general tissue death. Also, there is creatinine kinase myocardiobands, or CKMB. This is specific to cardiac tissue, so we can also look at that. But the gold standard is going to be troponin. So troponin is a protein released from damaged heart tissue, and it stays elevated longer than CKMB, making it the preferred lab for this purpose. So this would typically be ordered as a serial draw, meaning that they do the baseline, and then every couple hours, 3 to 6 hours, depending on the provider's order, they'll check the troponin and monitor the trend. Is it going up or is it going down? Then we have myoglobin. So myo is muscle, globin is protein. So any type of muscle cell injury in the whole body, just not the heart, we can look at a lab for that. Brain natriuretic peptide, or BNP, is released from overstretched ventricular tissue, and this is typically an indication of heart failure. So if we're suspecting heart failure, then they are going to have a BNP ran. So if in heart failure the muscle becomes very weak and the ventricles aren't able to really squeeze out the blood as well as it should, and they kind of fill up and stretch. So that stretching is what that BNP measures. And this is a summary of the labs that you would expect to be ordered for a patient when we're screening for cardiovascular disease, or if the patient has some type of acute chest pain or a full-blown myocardial infarction. Our next diagnostic studies is the ECG, or electrocardiogram. So this assesses the electrical conduction system of the heart. It is a 12-lead ECG, as you can see here where all those red dots are. That's where the leads are placed. So this can be done on a routine basis, or it can be done in an acute emergency basis. And it's going to give us a picture, a graphic recording of the heart's electrical activity. It can show dysrhythmias, it can show new or old heart muscle damage, electrolyte abnormalities, and heart hypertrophy. Okay, this slide shows the anatomical sites where the leads should be placed, so you get the optimal graphical picture. When an ECG is performed, it's important that the leads are placed in the correct anatomical position because each one plays a role in creating the graph that we see. So here you can see the different leads. They each kind of target and cross each other on the heart to get different information from whatever point that they are focused on. So the electrical activity from the heart when we do a 12-lead EKG is translated into waveforms like we see here, the P, Q, R, S, T, U. And you can see that we can measure each of these waves, intervals, and segments, and they can give us an indication if something is abnormal. For now, that's all we're going to say about this. For more in-depth, you can go to the dysrhythmia lecture. The next diagnostic study that we can use for a patient with cardiovascular disease or chest pain or suspected MI would be a chest x-ray. So a chest x-ray is very common, it's inexpensive, and most hospitals, if not all hospitals, have the ability to take a x-ray like this. So it can give some preliminary information about the size, shape, and position of the heart, but it doesn't diagnose like heart diseases per se, but it's a very good, fast diagnostic tool. The next diagnostic study is the echocardiogram. So this is an ultrasound of the heart. There are two types, transthoracic and transesophageal. So the transthoracic goes over the skin. So it's like that middle right picture, just goes over the skin, just like your typical ultrasound. Transesophageal actually goes down through the esophagus, and the ultrasound is done from the inside out. So that one is more invasive. So the echocardiogram can look at the pumping of the heart, blood volume status. It checks to see if the valves are working properly, and it has lots of measurements, lots of data, but we also look at the ejection fraction via an echocardiogram. Now the EF is the percentage of blood that is ejected from each ventricle with each contraction. So normally we don't expel all of the blood from our ventricles when it squeezes. 55 to 70% is how much we squeeze for a normal working heart. If you have decreased ejection fraction, we correlate that with heart failure. So the lower the number, the more severe the heart failure. Next is a cardiac stress test. So this test is done to evaluate the heart functioning during times of increased workload. So the whole point of the study is to give the heart a lot of work to see if the patient has any symptoms like chest pain, dizziness, dysrhythmias, or like shortness of breath, anything that's not normal, so that they can record it. It's important to have this done in a setting where there is emergency equipment available like a crash cart, because if we're inducing this extra workload on the heart and then the heart does end up having a myocardial infarction, there needs to be emergency equipment there. So in this picture, the patient is walking on a treadmill. That is the preferred way, the natural way to kind of have the patient exercise to induce possible symptoms. But if the patient isn't able to walk on a treadmill, maybe they have mobility issues, then they will have a nuclear stress test done. So the patient will get an injection of a nuclear isotope, which will mimic like if the patient was exercising. Next, we have the coronary catheterization, also known as cardiac cath. This is an invasive procedure where a catheter is inserted either through an artery or a large vein under fluoroscopy. So fluoroscopy is like a live x-ray. X-rays, they take pictures, single pictures. Fluoroscopy is like a video x-ray. And this can measure pressures in the heart, cardiac output, and also like how the valves are functioning. So this is performed in the cath lab. So if your hospital doesn't have a cath lab, a patient who needs this done is going to have to be sent somewhere else, because patients who have myocardial infarctions or really bad obstructions, they need to go to the cath lab. So then we have coronary angiography. So this falls under the heart cath. So this is the main reason why a cardiac cath is performed in the first place. So it's a left-sided cardiac cath, and the purpose of it is to check out the coronary arteries for blockage and determine whether some type of intervention needs to be done, such as a percutaneous coronary intervention or PCI. So this is when they're going to do something because there's an occlusion. Maybe it's a partial occlusion, but they go in and determine that yes, something needs to be done. They just can't take a look and then come back out. Also, coronary artery bypass surgery or CABG may end up being done because they just have really bad occluded vessels. And we're not going to get into CABG, but that is something, the ultimate. If you can't get it done in the cath lab via a catheter in an artery, then the CABG would be open heart surgery where they break through the sternum. Okay, so let's take a look at these pictures of a coronary angiogram. So on the left side, you see that there is a blue catheter there, and it looks like they went in through the femoral artery. They put the catheter in and went all the way up to the heart, and then they shot some iodine-based contrast in there so that they could see the vessels on the screen. And then that's where they can assess and see if there's obstructions or blockages. So you can see here they did do a PCI, a percutaneous coronary intervention. On the left side there is an obstruction and it was successful. On the right side you can see that nice blood flow circulation there. So complications that can happen post cardiac cath. Bleeding is going to be your first thing and most common because you are puncturing a large vessel, and usually it's an artery, so we're going to say artery. It's a high pressure vessel that can bleed a lot if you don't give it enough time to clot. Next one would be hematoma. So hematoma is like a little bubble of blood. Now sometimes you'll see that yes, you might develop a small little hematoma. Or it can turn into a huge hematoma. It can be under the skin, it can be outside of the skin. Either way, hematoma is not something we want to see, and you should report that. And then the third top complication would be an acute kidney injury, and that's directly tied to the iodine-based contrast that they inject in order to light up those vessels. So these are our three things. However, these are other complications that could also happen that are less common. So the patient can die from this, okay? So death is a risk. Patient can end up having a myocardial infarction post-procedure. Patient can end up with a pericardial tamponade. That is where the outside, the sac that the heart sits in, fills up with fluid, and that fluid puts pressure on the heart, and then the heart can't pump. The patient may end up needing emergency bypass surgery, a CABG, even though maybe they thought that they could fix the problem with just a heart cath, so they might end up going to surgery anyway. And then they are at risk for stroke because of clots. Maybe something broke loose, maybe a plaque broke loose. So we always have to consider these when the patient is recovering. So when the patient comes back from the cath lab and you are the RN taking care of this patient, you need to keep an eye on whatever site they access. So the top left picture here is an example of a radial artery access. They have a band. They come from the cath lab with this band on, and there is a little cuff with air. So your responsibility as the nurse receiving this patient is to monitor the site to make sure there's no bleeding. You also want to do your neurovascular assessment distal to wherever they access. So in this case, in that picture, would be the hand. So you're going to check cap refill, color, temperature, and you're also going to make sure that puncture site isn't bleeding. So following your facility protocol, you're going to use this special little syringe here that only fits this little valve, and you're going to remove 1 ml, 2 mLs of air, whatever your facility says, over however much length of time until you take out all the air, and then you can take the band off. So that is radial access. On the right side, you can see an example of the femoral access. These patients may come back to the floor with a sandbag, like so, and you have to be careful with this pressure because yes, you want pressure so you don't bleed, but you don't want to put too much pressure where you're occluding the vessel. So you just want to be careful with that. So here is what you need to remember as the RN taking care of a patient that just had a heart cath. So the patient, especially if you had a femoral access, they need to be in bed for at least 2 to 6 hours. That is going to be up to your cardiologist and or facility protocol, but they need to stay in bed. We want to make sure that they don't start bleeding out from that puncture site. You're going to monitor for bleeding or hematoma, including taking vital signs, because vital signs can indicate blood loss even before you see blood sometimes. These patients should still be on a cardiac monitor because they are at risk for a myocardial infarction and death. Patient should be told to report any type of chest pain or discomfort because that is not normal. Chest pain after a heart cath is not normal. We want to assess for signs of stroke because they are at risk for stroke after this. So left-sided weakness, slurred speech, confusion. You want to call a rapid response if that happens. We're going to do neurovascular assessment, so our pulses, skin color, skin temperature of the leg that was accessed or the wrist that was accessed. We are going to monitor urine output because the patient may develop an acute kidney injury. We want to make sure that they have lots of fluids to drink and IV fluids if ordered and if appropriate. We want to make sure we're also checking labs to assess renal function, their H&H for fluid status, and coagulation studies, just in case there's something abnormal there. And that concludes this lecture.